My name is Rebecca Pyuzza, and I attend University of Maryland School of Public Health, and I am focusing on public health practice and policy with a global health certificate. So it's a little bit different than everyone who's doing epidemiology or biostatistics, but I was very interested in the program, and I wanted to stretch my knowledge base and learn something different throughout this program. So my project focused on a difference in perception of women who assess breast cancer screening and those who refuse at Ocean Road Cancer Institute in Dar es Salaam, Tanzania. Just a brief background, I'm actually Tanzanian, so it was actually very exciting to actually go back and do research in my own country. So this is an outline of what I'll be talking about. Basically, the background of breast cancer, my original methodology, things that happened during data collection results, and key learnings. So brief background about breast cancer. So breast cancer is one of the most common causes of death in women globally, followed by cervical cancer. It has been on a rise, and it's estimated by 2025 that over 19.3 million women will will be suffering from breast cancer, and majority of those women will be in sub-Saharan Africa. And some of the factors that are contributing to this are low levels of awareness, documentation of prevalence of breast cancer, as well as most cancers being diagnosed at a later stage, advanced stages. So in Tanzania specifically, breast cancer is the second common cancer and the second leading cause of mortality, cancer mortality among women in cancer, followed by, the first one is actually cervical cancer. So it's predicted by 2030 that 82% there'll be increase of new breast cancer cases. And right now, currently, 80% of people who are being diagnosed already are in advanced stages of breast cancer. So I wanted to find out why this is happening and what's going on. So my overall objective was to compare epidemiological, demographic, and clinical data to predict the reasons why some women subscribe to breast cancer screening and why others refuse to enroll in breast cancer screening projects. So for my original methodology, the goal was to interview 300 survey participants. I split them up into two groups. The first group was a case group, and these are the women that are actually coming to the clinic for breast cancer screening and agreed to be screened. And the control group that I wanted to compare against were people who are female relatives or friends or patients who are coming into the clinic either to support breast cancer screening patients, or come to be seen for cervical cancer screening. So at Ocean Road, they have a cancer screening clinic. So at the cancer screening clinic, you either come in for cervical cancer screening or breast cancer screening. So I developed a questionnaire that basically touched 4 different topics. Demographic data, where I collected the age, income, education level, employment, where they lived, general medical record information, and I also took down their patient ID number so I can further go back and review if they were diagnosed or they weren't diagnosed. And I also asked about perception of breast cancer, what did women understand about breast cancer, and their knowledge about breast cancer. So data collection procedures, what I did was I went ahead and I recruited the women at the clinic every day when they came in. So the clinic opened from Monday to Thursday between 8 a.m. to about 1 p.m., and the woman would be given a number upon arrival based on what they were being screened for that day. So I individually approached each woman before or after their computer registration to gain participation. So after they got registered in the computer, I would then contact them and talk to them and do the interviews. So I conducted all the interviews in Swahili, and the interview took about 25 minutes to complete. So during data collection, I learned a few things along the way, which kind of changed my original study project. I learned that women in the control group, these are the women who are actually coming in to be seen for only cervical cancer screening, they were given opportunity to be screened for breast cancer screening as well. So the thing is that in Tanzanian culture, if a doctor tells you to do something, you're gonna do it. There's no like, oh no, I'll come back later. Most likely they're gonna sit there and get the service done. So refusing services was not is not culturally acceptable. So most women who came in for cervical cancer screening also got breast cancer screening done. So I thought that was actually a benefit for the women, but it kind of changed the way my original methodology was going to be going. So what I decided to do with that was compare the results for the medical and family history as a point of comparison for the two groups to find out if we actually got women who were diagnosed with breast cancer afterwards. And then during the data collection also, I noticed that I had to modify my questionnaire. So my questionnaire had a terminology risk factor. Even though I translated it into Swahili, it was still hard for women to understand what I meant by risk factor. So I had to replace that terminology and use simpler English or simpler Swahili, so that they'll be able to understand what I was trying to ask them. So I cut down the 10 questions that I asked about risk factors into 3 questions, and then I added photos. So on the screen right there, you'll see exactly what I changed it to be, so it was much simpler, and I noticed that people were really understanding what I was saying and answering the questions related to breast cancer. So next I'm gonna talk about results. So there's still work to be done. After collecting all the data, I'm working on cleaning it, making it pretty, and being able to analyze it. But what I do plan on doing is developing a regression model based on initial analysis and significance of the comparison tables. What I'm going to do is use breast cancer screening question as a dependent variable, and then also the predictors of variables of significance in the table. So what I'm going to do next is just talk about the brief demographic results that I have and the things that I found interesting from it. So next, this graph here is about the age of participants. The blue are the case control group, and the orange are the control group. I don't think you guys can see the numbers very well, but I'll explain it. So in the case control group, these are the women who were actually breast cancer screening patients. I noticed that there were a lot of women who came in between the ages of 18 to about 34, which I found very surprising, but I think it was just from talking with the women, I think they were just very worried that, oh, I have a pain, but I don't know what it is, and I think I might have breast cancer, so they came in to be seen. And I noticed in the control group, it was about older women between the ages of 35 to 54 that came in to be seen for cervical cancer screening. The education level was pretty much the same in case control group, where mostly primary and secondary level of education, while in the control group was very primary level education. So that spoke to the reason why I had to change the survey and make it simpler for the women to understand. In the occupation level, most women were either business owners or housewives. So the term business owners would be kind of a loose term because it's not really big businesses, it's more small business owners, either women who sold vegetables, fruits, made like pastries, things of that nature. So that was like their considered business owners, more considered entrepreneurship. And last but not least, the results, I noticed that most women were in the urban areas rather than the rural areas, although it wasn't just only centered in Dar es Salaam, but there are other urban areas where the women came from to be seen at the screening clinic. Oh, okay. So this is a picture. The middle picture is the one of the Cancer Institute. And I took a picture of one of the cards that the women receive at the clinic. That's what they receive that card after they're seen with cervical cancer screening. They're given a card, and it tells them the results inside the card, and then at the back of it, it tells them the appointments that they're supposed to return. So I thought that was very interesting, but I didn't see that same thing for breast cancer screening patients. So I thought that was something that they could actually add. And then the picture on the top right is just where they came in to be seen. It's like they enter in there and sit there and then are seen later. So key learnings. I learned the breadth and depth of Ocean Road Cancer Institute. I learned about the screening clinic that I was mostly at, and along as well as the other services that are provided at Ocean Road. I thought it was really wonderful that Ocean Road provides them with free screening, and then after they're screened, they are, if something is found to be suspicious, they're told to go get tested. And once they get tested and find out they really do have cancer, they are offered free treatment at Ocean Road. So I thought that was actually really exciting. But also with that, it's in the capital. So with people who are diagnosed and can't come back, that would be a barrier. I also learned that patience is a virtue. Some things take a little bit longer to start, and just learning how to be patient and trust the process was one of the things that I learned this summer. One of my highlights, a few of my highlights were interviewing the patients. Being that I am Tanzanian and I have a background in speaking Swahili, it was very interesting coming in because I was kind of seen as a foreigner, but I spoke Swahili, so they didn't know who I was. So it's very interesting to interact with the patients, but it was a rewarding experience to actually be able to actually interview the people and get my exact data and not have to rely on a translator to be able to translate the data for me. And I'm learning how to analyze data through this process. It's very interesting. I'm learning how to use SPSS, so yeah. And I gained an interest in cancer research. Initially, when I saw the program, I was like, well, I don't know anything about cancer, but I was like, hey, let me just go for it and see what I can learn. But I did have an interest in global health, so I think it was really rewarding to kind of find another area of interest. So that was one of my highlights for the summer. And lowlights, of course, all good things have to come to an end, so that's that. But I hope to, do other things. So strengths and limitations of ORCI. They had a really good professional, knowledgeable staff at the clinic. So what they do at the clinic is offer education when the women come in initially in the day before they're seen for either breast cancer screening or cervical cancer screening. So I thought it was really interesting. I sat down and listened to some of the education provided. And it was really nice. I consider the screening clinic to be a one-stop shop because I noticed that even though they came in for one particular thing, they were also seen for the opposite thing. So I thought that was actually really good. So you're just not just hitting them where they think they need help in, but also if they need some help in another area, that's also provided to them. So one of the things I would improve about ORCI is the patient experience. The sign-in system was a little bit awkward, but I really appreciated that they had an electronic medical record system that they were really trying to use and they were trying to put into place. So I thought that was actually really good that they collected the appropriate data at that initial sign-in portion. And I would improve actually the breast cancer flyer. The flyer, I had a copy of it, but I'm not sure if I have it here today, but it was very wordy, and it was just words on like a flyer. And even for me, and I'm educated, I would probably just read a little bit of it and put it down. It wasn't as attractive to capture that audience. So if someone who can't read, who has a primary level education, that's gonna be a barrier for them to understand what actually breast cancer is. So I thought that was something that they need to improve. So for future research ideas, I would examine the retention of the patients. Seeing that breast cancer right now, everyone's being diagnosed at a later stage. For those who are actually coming in and being seen, I think it would be a good research idea to follow up and see if they actually did go back and pay for that treatment to see if they actually do have cancer, even though that they were said that something's going on, to see if they actually come back and get treatment, or just wait and like, it's okay, it's not that serious just now, and come back at a later stage. And I think that ORCI can implement a text reminder system to ensure that patients follow up on their upcoming appointments. I thought it was very interesting for those who come in for cervical cancer screening, although that wasn't my focus on what I did my project on, but they were either given a follow-up of 14 months, a year, or 3 years. So it's very interesting to see how the people would come back for those upcoming visits. And I would also do a future research idea on acknowledging the knowledge assessment of the information provided at that initial visit. Like I said earlier, at the clinic, they are given education in the beginning before they're being seen. So I want to see how much information will be retained from that. And then also cost-effective analysis in the breast cancer clinic itself. That arm of breast cancer clinic it just opened a year ago. So it's very interesting to see if it's actually if it's beneficial to the public. So my future goals are to graduate in December. I want to pursue a PhD in health services and policy implementation, focusing on global health, and I would like to work for an international company. It doesn't have to follow that particular order, but those are some of the things I would like to accomplish in the future. Some acknowledgements: I would like to thank ORCI for the opportunity to be there for the summer, Dr. Suleiman and the CEASE program, and then also my on-site mentor, Dr. Masami, and also the clinical breast cancer screening staff. So that's it, and questions?
But I want to warn you against two things. One is being myopic, not being able to take a sort of longer view of things. But also, you folks are epidemiologists. You're number crunchers. I would contend, and I'd be willing to back this up with numbers, that screening women for breast cancer when they come in for a cervical cancer exam is actually a terrible idea, okay? And especially in a low-resource country. Take a look at the age distribution curves for breast cancer and cervical cancer in any registry. Okay, the women who are the optimal age for screening for cervical cancer, 99.999% of them do not have breast cancer. Okay, so you are going to take a low-resource country where the medical staff is stretched anyway, and convince them that they're going to do a breast self-exam when women come in for cervical cancer screening. It is absolutely wasting time. The yield of that is going to be minuscule. Okay, it seems like a good idea, one-stop shop, why don't we do this while we're at it, this sort of thing. But when you have a system where you have people waiting to be treated for infectious diseases and other things, you just cannot afford the luxury of doing a breast self-exam on a population that is 99.999% free of breast cancer. And even the fact that women have a lower average age for breast cancer in many of these countries, even that's misleading, because the reason they have a lower average age is because the average age of everybody is lower. The average age of people who trip over a cat is lower in Zambia than it is in the US, because the age is skewed toward younger populations. It does not improve the yield of a breast cancer screening program in young women, which is frankly just a bad idea. It's not a good use of resources. So I think that when you are looking at these programs that exist in various places, and there are many people who've been involved in this in years who are still myopic and don't actually crunch the numbers. But I'm going to encourage you folks to look at the numbers you have in front of you from the registries and whatnot and make sensible decisions about use of resources, not just because, gee, it seems like a good idea, why don't we screen for breast cancer while we're doing cervix?
I disagree. So I like to disagree with Dr. Harford. And, you published the paper about the lack of effectiveness of mammography and population-based screening in developing countries because of you screen 5 million women, you find 50 cases. But I see advantages for having a program like this. Number one, if you look at the cervical screening program of ORCI in Tanzania, maybe the program is called cervical screening, but it's not actually entirely cervical screening. You have about 40% of women coming with infections and manifestations of something that they find a place to go to for treatment. That's number one. Number two, there are women, especially for breast cancer, who have a breast mass or pain or whatever, and they are waiting for many years, and this is an opportunity for them to come forward. Third, this program is not population-based. Fourth, talking about breast cancer, showing that there is an opportunity for early detection or downstaging or early diagnosis, as you used to call it, is important because you remove the stigma of breast cancer and the fear of breast cancer. Breast cancer groups and advocacy groups now in Tanzania are doing a fantastic job because of talking about breast cancer and getting people to hear about breast cancer and seeing cancer survivors. Fifth, it's important to talk about the disease and do something, even for downstaging, when you have 90% of the cases as stage 3 and stage 4.
I won't go through 1 through 5. But the point is that if you wanted to work on downstaging, you could look at proven ways and that have been documented as to how to achieve downstaging. I don't think you'll find that any papers that support an appropriate program for downstaging is to introduce breast cancer screening in a cervical cancer screening program. I'm not taking exception with the fact that reducing stigma and doing downstaging and getting women to talk about breast cancer, all those are great things to do. And there are ways in which they could be done in a cost-effective way. I don't think that simply creating the one-stop shop of cervical/breast cancer is necessarily the best way to do that. And I don't think there's any data that would support that. I think what you have is a situation where people are faced with, we can't do everything, and so let's try to do something without necessarily, and this is where myopic comment comes in, without necessarily evaluating whether that particular approach is in fact effective. So I agree with everything you've said about the need to reduce stigma and the need to talk about breast cancer. I just don't think that taking an already stretched rural workforce in the medical care with all the things they have to do and introducing breast self-exam for every woman who comes in for a cervical cancer screening is a cost-effective use of their time. I think that you could, when they come in, if you say, is there anything bothering you, and they say, yeah, I have this big breast mass, then you could do that. But the idea here is you're introducing clinical breast exam into this program. And clinical breast exam, you can calculate how many minutes it takes, what the yield is, et cetera. And it's just not a good idea. It's not a good use of time.
I was going to say thank you for your presentation. One of the things that struck me that is probably the richest part of what happened is the conversations that you had with the women, and I can just imagine the trust that they would build. People go into a doctor's office don't talk 25 minutes to anybody. I mean, they sit there and look at each other. So having somebody who comes from a different country come up and talk to them in Swahili must have been unbelievable. And I would bet that there's some insights in that qualitative data. Mm-hmm. And one of the insights I'd wonder if there was there is, these people came. They were at Ocean Road, and they were with their friends or relatives or something. And how can the messages that they gave you affect the people who won't come or didn't come? Can you build a message to those people who are out there at high risk in the community who aren't coming for screening too. And I would suggest you think about that and the conversations, the richness of the conversations you've had, and what people said about those pictures, you know, and things like that, and what it meant to them, and how that could lead a conversation to bring more people in to screening.
And this reminds me of how important it is to do simple observation going into a research project. The first time I took a tour of the Ocean Road Cancer Center, maybe 20 years ago, I observed that they had no surgeries. Here's a cancer center, and one of the primary modes of treatment, of course, is surgery. And they had no surgeons, and they had no surgeries. And the leadership of the Ocean Road Cancer Center at that time were primarily radiation oncologists. And then in the tour, I remember passing through the area where these cervical and breast cancer screenings occurred. And it wasn't until maybe a week later that I was thinking, well, those who are positively screened for these two cancers are not in an organization where the primary treatment would be surgery. And as I questioned this sort of inappropriate range of health services, they explained that, well, surgery is done across town at the Muhimbili University Hospital. And so I'm thinking, well, shouldn't the screening for these two cancers occur over there? And the historic, the political organization of these services in many places, including the United States, are not necessarily logical. And the history is often lost, and they can't exactly explain why these things are as they are.
One of the other things I was thinking about as you were talking is any insights you might have on what types of environmental things might welcome people into the screening clinic. And I say this in the context that doctors' offices that have like rainbow symbols and stuff like that are immediately taken to be LGBT-friendly places, you know. And I don't know if there's any equivalent to those types of symbols. You know, as you showed the entrance to the welcoming that could welcome people, that you had some insights from the people you talked to. What things would welcome people into
So I think that from when they came in, they had like signs, but I think that what would be better is some type of direction, because it's at the back. When you come in to Ocean Road, there's two entrances. There's a main entrance where you go and get treatment for cancer, and then there's a back entrance where you're coming in to do the cancer screening. So it was very interesting because if you go through the corridor, you'll see like a sign. But the sign is not that big. It's very like small, and then you might have to ask somebody, oh, where do I get screening done? And then they'll direct you. So I think bigger signage, clearer instructions on how the process goes would be beneficial to the people who are actually coming in and getting screening. So I think they didn't even have like posters about cancer, breast cancer or cervical cancers that were out in the main area. So I found that very interesting. You're sitting there, you're just like, well, they just gave me this flyer and now I just wait. And I'm like, all right, then your number is called. Then you go in and then you get seen. But I think it would have been better if they had like a lot of like different signs and things of that nature to help with the process. So just in case you're like worried and you're sitting there and you're like, okay, well, at least I know something now. outside of the education that you're given.
I want to mention one last point. This workshop is for career planning and career development, and I want you to think about how you would advise Rebecca and others about their future career planning and their future steps. I see advantages of having her speaking Swahili. I see advantages of having her going from a Department of Health Equity into cancer epidemiology. I see advantages of her learning about cultures, and she could market herself in different ways. And this is something that we need to talk about later today and tomorrow about future career planning and what students and graduates of this program could be thinking about in terms of future options for career planning. Don't feel bad about yourself that you came to a cancer program and you were not interested in cancer. 95% of the students who came to this program were not interested in cancer. So I'm looking here at every single one here, and when they came to the program or came to work with us, they were not interested in cancer. I remember Dr. Cantor was resisting, HIV person, I'm not going to do cancer, I want to do something like this. Dr. Vogtman was interested in infectious disease, I'm not going to do cancer, I'm not a cancer person. Dr. Tomey was interested in social epidemiology, I'm not a cancer person. And Dr. Leanna May was in global health, not necessarily cancer. So we forced her to Melissa Bondi and MD Anderson, and she ended up being a cancer person. So this is the aim of this program, and that's why NCI funds this program to create a new generation of experts in cancer research and cancer epidemiology.